Today we're going to talk about instrumental assessment of swallowing. Specifically, we're going to discuss 3 different types of instrumental assessment. That would be FEES, FEAST, and MBS. You're certainly familiar with the MBS method for assessing swallowing. We'll talk about it again sort of in an overview sense, but let's go ahead and start looking at FEES and FEAST, the methods that you're not familiar with yet. FEES stands for Flexible Endoscopic Evaluation of Swallowing. Now, when you do a FEES examination, you are taking an endoscope, that same endoscopic technology that's used to evaluate phonation and voice disorders, and you are passing the scope transnasally over through the nares, up and over the soft palate, such that the light and the camera in the endoscope are hanging down and can view the surface of the vocal folds. So, in this methodology, you can see actually the surface of the vocal folds and all the other structures in the laryngeal vestibule and beyond. When the vocal folds open, you can see into the airway via the trachea. You can view the vocal folds immediately before and immediately after a swallow, but you cannot view the vocal folds and the rest of the vestibule during the actual swallowing moment. That's because there is a moment during FEES called whiteout, and that is caused by the action of the epiglottis, which flops down over the vocal folds and obscures our view. All we can see is sort of the white light from the endoscope reflected off of the epiglottis. We'll see what that looks like in just a moment. Let's talk about why FEES is a useful methodology for evaluating swallowing. Well, you can observe the vocal folds directly, so you don't have to look at a lateral or an AP view and try to infer what the vocal folds are doing. You can see what they're doing. You're able to see patients bedside, so you are not in a medical center restricted to those patients who are healthy and who can be shuttled on down to imaging or radiology. You can also take a small FEES unit with you to other locations other than a hospital to do your assessment. So people in a skilled nursing facility can be evaluated. There's no radiation using FEES, and because it's portable and it does not usually damage any structures, it actually can be used as sort of a visual form of biofeedback when you're working with patients and you're trying to get them to use a particular technique or show them that they've improved or not improved. Let's take a look at what it actually looks like. Here's the actual setup, and this slide is taken from the Susan Langmore article that is posted on your website for you to take a look at, and I highly recommend that you review that article. There's film footage as well as a very detailed explanation of what this technology is like. So here we see a clinician, and I believe it is Susan Langmore, who is using an endoscope to evaluate the person who's seated at the table. She will be giving her instructions about what to do and what not to do, and she'll be narrating at the same time. So when she goes back later to view the film, she'll have an auditory log of what they were doing at the time the film had taken place. So again, you can see if there was a small monitor and a packaged briefcase arrangement of the computer aspect, you could very easily travel with this assessment procedure. Here are the landmarks that you would typically see in a FEES view. So we can see the arytenoid cartilages, those sort of lumpy projections in the posterior aspect of the vestibule. You can see the vocal folds, and when they're open, again, you can see the rings of the trachea underneath. Now, if we take a moment and look next to the vocal folds, you're going to be able to see these sort of pads of tissue here, and we often think that this is just part of the vocal folds. That's what naive sort of viewers might think looking at this, that this area here is flat. But it's not. These are projections of the false vocal folds, which are located above the true vocal folds here. But because we don't have that sense of depth perception, it really does look just like it's sort of flat, but it's not. Here's one and here's the other, false vocal folds protruding into the airway. Back here is the epiglottis. Now it is in the upright position, but you can imagine when it is folded over to protect the opening into the trachea that we're not going to be able to really see anything. There's also a nice view here of the piriform sinuses. Here is one, and here's the other. They're sort of between the root of the tongue and the epiglottis. Now this picture is from the link also on your website to what FEES looks like in action and what an abnormal view of the swallowing mechanism might look like. And you'll have to forgive the poster who wrote aspiraton instead of aspiration. If you look closely, you can see blue here. And that's certainly not a color that normally occurs in the laryngeal area. Things are blue during an abnormal swallow, in this case swallowing material that goes all the way into the airway, not just on the surface of the vocal folds. That's because we mix blue dye with the substances that we ask someone to swallow during FEES. That way we can be assured that when we look down and we see material, we know it's not just mucus. We know it's actual PO substance that was swallowed and is being either well, if it's touching the vocal folds and going below, it's aspiration. Okay, so we've seen sort of the basic landmarks. We've seen what it looks like when there's an abnormal swallow. We will come back to FEES when we talk about the relative benefits and relative negative points in another follow-up lecture. I do want to take a moment to say something about FEAST, which is very, very similar to FEES, flexible endoscopic evaluation of swallowing, but it is with sensory testing. Now in this view, I'm going to point out a couple of things. One is you can see that there is mucus in the general region of the laryngeal vestibule and fairly close to the vocal folds. And what this means is that it's a good thing that we use that blue food coloring or blue dye when we're doing swallowing assessments, so we can be assured that something is a food substance as opposed to the body's own secretions. The second thing that I want to point out is this duct right here, and that duct introduces a spurt of air into the larynx. Now, why would we do that? Because that is the sensory stimulus that we will use to see if the larynx reacts to a sudden burst of air. A normal reaction would be for the vocal folds to close. The vocal folds don't know it's just a blast of air. It could be anything as far as they're concerned. So it does give us a good view of what happens in terms of reaction to sensory stimulus, and particularly for those patients who have had cranial nerve damage, sensory damage, and we want to know if they're providing the sensory information to the swallowing center that they might need to have a healthy and safe swallow. This is a useful technique. I'm going to refer you to the website that's at the bottom of the page. This is a website for a particular company that does feast testing, so you'll have to take it with a grain of salt, but it does have, in addition to an explanation of the technique, some pictures as well as film of normal swallows, of abnormal swallows using feast technology. The thing about feast examinations is that it does not exclude the possibility of getting the information that you get with fees. So you could do a quick assessment to see how the vocal folds react in terms of airway protection and after introduction to a stimulus. Then you can remove the duct and you can do a fees assessment just like you would under any other circumstances. I will say that fees and feast both use the same kinds of PO substances that you would use in any assessment of swallowing. So whether it's a clinical assessment or an MBS assessment, it's going to be the same set of materials. Thin and thick liquids, solids, purees, and then any idiosyncratic materials that you are interested in. The only difference would be the blue dye that you need for fees and feast. Okay, a few words about your well-known MBSS or VDSW. Those initials stand for Modified Barium Swallow. Sometimes there's a second S study, or a video swallow. Again, same PO substances that you would expect under any circumstances. This technology, as you know, requires that the person ingest those PO substances mixed with some kind of radioactive material, usually liquid or paste or powdered barium that is mixed into the food substances. Just like with fees, you might want to start with the person swallowing their own secretions first, just to give you sort of a dry run of what the status of their swallowing is. Then you're going to administer typically a small amount of liquid first, and it can be water. It's just going to be water mixed with a little bit of barium. And you can gradually repeat and advance. So you might give one small half a teaspoon amount. You're not sure what you saw, or you'd like to see what happens again. You re-administer. And then if the person is doing well, you might have them do serial sips or serial swallows to get a feel for what is happening during sort of normal drinking of fluids. And during this time, you're going to be noticing, are they drooling? Can they contain and form a good bolus? Once you've administered other substances, for example, purees and solids mixed with barium, you're going to take a look at all of the things we would look at and be interested in all of the stages of the swallow. So bolus transit, bolus propulsion, the action of the tongue, the movement of the soft palate. After the swallow is over, you're going to check for oral residue everywhere in the sulci, in the anterior aspect, on the palate. You're going to check and see if there's been any premature spillage, and or if there has been any unexpected characteristic to the transit of the bolus as it proceeds from the end of the oral stage into the beginning of the pharyngeal stage. And you're also going to be checking out how the person is able to chew, if their mastication is functional for the things that they would like to eat. When you look at the pharyngeal stage, the next stage, of course, you can see in an MBS, you're going to be looking at how the bolus needs to be positioned before the swallow is triggered. And we've talked about some of this when we were talking about last week in our Collaborate section, when we were talking about the bolus passing the ramus of the mandible. You're also going to be checking the sort of functionality or adequacy and the timing of all the other activities that are in this stage. So you want to make sure that there's good VP closure, that the epiglottis inverts, that there's laryngeal elevation and anterior movement of the hyoid, and that you start to see that characteristic pattern of the pharyngeal constrictors as they squish the bolus inferiorly through the pharynx. As you move towards the end of the pharyngeal stage, you're going to be checking out to make sure that the PES is opening. And you're on the lookout for abnormalities of all kinds during both the oral and the pharyngeal stage. In the pharyngeal stage, you're looking to see if there is penetration and what are the characteristics of that penetration. If there is aspiration, and once there is aspiration, does the patient react in any way, or do they have silent aspiration? That is, aspiration without the person seemingly being aware of it, and without coughing, without gagging, or attempts to clear the airway. If you happen to see aspiration during your MBS, you can ask the person then and there to try and clear that material that is penetrating between the vocal folds with a voluntary cough, and see if they can get most of the remaining bolus in the vestibule out of there. You're going to also be able to do the same thing that you did in a FEES assessment, and that is if you see pharyngeal residue, if you see even for oral residue, you're going to see how much they can clear if you have them do a repeat dry swallow. This is also called double swallowing or a second swallow. The esophageal stage is definitely something you cannot see when you're doing FEES and feast. It is one of the unique kinds of information that you can get from an MBS. You're going to be checking out the opening and closing of sphincters, and in the typical view, you're going to be watching to see if there's any kind of backflow of liquid, of material from the esophagus back up into the pharynx. You're going to be checking out to make sure that the esophagus at the top of the opening is wide enough to allow food and liquid to pass through. Now I'd like to say a few words about the AP or anterior-posterior view that is sometimes used on an MBS. Typically, this is not done right away at the very beginning of an MBS or a video swallow study. It's done towards the end of the study, and not exclusively. I know I said here thin and thick liquid boluses, but sometimes you might also try puree, and you're using it for patients where you suspect there might be some asymmetry. So stroke patients spring to mind who could have unilateral impairment of action of the vocal folds and the pharynx and the oral structures. So you're looking to see, as the bolus material goes down both sides, how symmetrical that is. You're looking to see if there are any weird anatomical variations that weren't clearly defined, and that shouldn't say AP view, that should say on the lateral view. Typically, at this point, the radiologist is also looking at the film, and they're taking a look especially at the esophagus to help rule out whether or not there are esophageal stage abnormalities of the structure. So the speech pathologist is concerned with the flow of the PO substance, and the radiologist should be helping you evaluate the status of the overall anatomy.